is at the Neanderthal level of emails. If it doesn't come in, could I have you introduce yourself? Is that
Hi.
okay? I just want to make sure we get it all.
All right, folks, welcome. It's 11:04. I think getting started. People might continue to filter in, but why don't we get rolling? So welcome to Innovations in Criminal Justice, one of our first panels for the BARI conference for today, one of three that are going right now, 11 to 12. So I'm going to turn it over to our moderator, Reverend Jeffrey Brown. He is at the 12th Baptist Church in Roxbury, which is his official title, but he's also, and I think very importantly, a really important civil rights, but also leader in youth and gang violence reduction here in Boston, famous for his work as part of the 10-Point Coalition in the 1990s, and really bringing together not only clergy, but also youth leaders, government, and the youth themselves to figure out how to construct the Boston Miracle. And so I can think of no better voice right now to help us have a conversation today in 2021 on how we innovatively move forward with questions of criminal justice and law enforcement, especially given the conversation we just had with former Speaker DeLeo. I'll also note that the Reverend is co-chair of King Boston, which is a really important initiative going on in the city right now in thinking about how we create a new Boston that is inclusive of all of our members, residents, and voices. So with that, I'm going to go on video and audio mute and turn it over to the panel, which is who you're here to see, and I will let the Reverend take over.
Thanks, Dan. I really appreciate that. And good morning to everyone. We do have a very exciting panel for you today. And what we'd like to do is introduce everyone. And then once we go through the introductions, then we will see video of each of the four areas in which we will explore. And then after that, I'll ask a couple of questions to get us started. And then hopefully you all will be able to ask your questions as well, and we'll be able to get them in there so that we can have a dialogue of what kind of innovations we seek around criminal justice. So let me do the introductions. I've got some heavy hitters here, so we've got a lot of words to say. So. First, I'd like to introduce Stephanie Roberts Hartung. Can you just wave so everybody would see you? She's a professor at Northeastern University School of Law. She is the resident fellow at the Center of Public Interest Advocacy and Communication and the principal investigator for CPAC's Cradle to Prison Pipeline Research Project. Professor Hartung was recently appointed to the faculty affiliate program at Boston University's Center for Anti-Racist Research. And she also serves on the board of the New England Innocence Project, and her research focuses on wrongful convictions, post-conviction procedure, and criminal justice reform. Next is Erin Stewart, who is in her third year of law at Northeastern. Erin, are you here?
She is here in the audience.
Okay. Well, let me just say quickly about Erin. She's a student researcher for the C2P project, which is the Cradle to Prison project, and is co-author of the Prison and Jail Study. While earning her undergraduate degree in economics, Erin worked at a public middle school in South Seattle. She also served as a court-appointed special advocate representing children in abuse and neglect proceedings in Washington State. And she'll be beginning a Skadden Fellowship at Citizens for Juvenile Justice in the fall of 2021. Her lifelong commitment is to improve systems along the pipeline to benefit our nation's youth. Next is Dr. Melissa Schaefer Morabito. Did I get that right? Thank God. She is an associate professor at the University of Massachusetts at Lowell in the School of Criminology and Justice Studies, and an associate at the Center for Women and Work. She has an MSW from Columbia University, received her PhD in Justice, Law, and Society from American University. She was previously a postdoctoral fellow at the National Institute of Mental Health, funded Center for Mental Health Services and Criminal Justice Research. And prior to her academic career, Dr. Morabito was a policy analyst at the Department of Justice Office of Community-Oriented Policing Services, or the COPS program, where she focused on police response to social problems in the community. Her research interests include understanding the intersection between police and public health challenges such as mental illness, domestic violence, and substance abuse disorder. Dr. Morabito has worked with the Philadelphia, Chicago, Lowell, and Boston police departments. Most recently, she finished a National Institute of Justice project where she was co-principal investigator, decision-making in sexual assault cases, replication research on sexual violence case attrition in the United States. That examines case proceeding in 6 jurisdictions across the United States. Her work has been published in Criminology and Public Policy, Crime and Delinquency, and Psychiatric Services. Dr. Jenna Savage, do we have Jenna on, or is she in the audience?
She's in the audience, but she's here.
Well, let me just introduce her. She's the Deputy Director of the Boston Police Department's Office of Research and Development. Oh, I know Jenna, where she has worked for over 10 years. In this role, Jenna's responsibilities include working with various academic partners to design and implement research projects for and evaluation of BPD programs, developing, monitoring, and overseeing program implementation and management for grant-funded projects to ensure project success and compliance, coordinating the BPD's partnership with the Boston Emergency Services Team, or BEST, out of the Boston Medical Center, representing the Boston Police Department in various settings, including intergovernmental hearings, professional conferences, and external agency and community meetings, and assisting with all aspects of office leadership and management, including supporting existing staff and screening new staff for hiring. Other responsibilities include data analysis, crime mapping, grant writing, and project management. Next is Morgan Wilson. Morgan is a legal fellow with the Domestic Violence Institute at Northeastern University School of Law, where she directs the Legal Assistance to Victims program for first-year law students. The LAV program works with community partners to provide legal support, safety planning, resources, and referrals to victims of domestic violence and sexual assault. Morgan also assists Professor Margot Lindauer in managing the DVI Legal Clinic caseload, as well as other DVI projects. Morgan's academic research focuses on racial and carceral capitalism and the prison industrial complex. Prior to joining Northeastern, Morgan worked at the Department of Justice in Washington, D.C. as the Director of Scheduling and Advance for Attorney General Eric Holder. And in her capacity as director, Morgan worked collaboratively with local, state, national, and international organizations and government entities to successfully develop interagency partnerships. She received her LLM from the School of Oriental and African Studies in London, where she graduated with honors and won the Best Overall LLM Award for the law school. Her research examined the relationship between carceral capitalism, race, and policing in the United States. She holds a law degree from Northeastern University School of Law and a BA from Boston College. Let me also introduce Gemma McFarland. She's a PhD student in sociology at Northeastern and has been working with the Domestic Violence Institute since January of 2020. Her work at the DVI is centered around the creation and implementation of data collection and research processes. Prior to entering Northeastern, she worked as a family advocate at the Community Advocacy Program in Boston, working directly with survivors of domestic and dating violence to provide crisis intervention, counseling, advocacy, and other direct services. Gemma's research interests are at the intersection of sociology, criminal justice, and public health, particularly within the context of intimate partner violence and victimization as a manifestation of social inequality and systems of oppression. She holds a master's in public health at Northeastern and a BA in journalism from Quinnipiac, I think it's called, Quinnipiac University. And our last presenter will be Miss Laurie, Professor Laurie Becker. And Laurie, I do not have your bio, so if you can just introduce yourself, please.
Sure. Good morning. My name is Laurie Becker. I completed my master's coursework in criminal justice at Roger Williams University, and I'm currently pursuing a doctoral degree in the School of Criminology and Justice Studies at the University of Massachusetts Lowell. My primary research interests include policing, opioids, and the intersection between law enforcement and public health. My research has most recently been published in the Journal of Drug Issues, and I have presented at many national and regional conferences, including those of the American Society of Criminology, the Academy of Criminal Justice Sciences, and the Midwestern, Northeast, and Southern Criminal Justice Associations.
Wonderful. And thank you all for being a part of this wonderful panel. And I'm sure we'll have some wonderful presentations that are coming now, along with the conversation that will follow. So now we'll take a look at the videos of each of the four presenters, and then after that, we'll come back with some questions.
Hello, I'm Stephanie Hartung, and I'm a professor at Northeastern Law School. I'm here with law student and senior researcher Erin Stewart. We're thrilled to share our work in Northeastern's Cradle to Prison Pipeline, or C2P project, an ongoing long-term interdisciplinary research endeavor. I'll provide a brief overview of the purpose and scope of the project, and Erin will share the preliminary results of the prison survey component. Our project is a collaboration with the Law School, School of Criminology and Criminal Justice, the College of Art, Media, and Design, and the Boston Area Research Initiative. At its core, the C2P project stems from a recognition that the Cradle to Prison Pipeline is a stark illustration of structural racism, a web of systems that interacts from birth to adulthood, disproportionately sending BIPOC and other marginalized children on a road toward incarceration. Our motivating principle is a desire to understand the complex workings of the C2P pipeline and its impacts in order to develop and support meaningful interventions. There has been much scholarly discussion of the school to prison pipeline in recent years, and in particular, how policing in schools, school discipline, and juvenile justice contexts disproportionately impact BIPOC youth and result in greater adult incarceration rates. However, the C2P project focuses on the early and underexamined aspects of the pipeline, with a particular emphasis on the child welfare system. All of our research is located on the website indicated here, and I invite you to explore the collection of resources. Our website provides a resource for students, scholars, practitioners, and policymakers to better understand the less visible aspects of the pipeline. I'll briefly address some of the main components. First, we have sought to center the lived experiences of people who have been impacted by the pipeline. To that end, we've partnered with Everyday Boston to create video narratives that animate the pipeline phenomenon and the human impact behind the statistics. Next, with the assistance of a team of social justice data analysis and designers at CAMD, we undertook a comprehensive data collection project to create a map of the complex and multifaceted pipeline to better understand how it operates in Massachusetts. However, while the data on juvenile justice outcomes have been more readily available in Massachusetts, the publicly available child welfare data has lagged significantly behind. To address these data gaps and to test the hypothesis that racial disparities exist at every stage of the system, we spent the last year developing and executing a comprehensive survey of incarcerated people in Massachusetts, with a focus on early childhood experiences and systems involvement. While COVID presented some challenges, we've completed phase one of the project and an analysis of over 250 surveys. And Erin will now review some of our preliminary results.
Hello, everyone. I'm going to start with demographic information and then go into the cross-tabulated survey answers. So looking specifically at our race demographics, we are 40% white, 21% Black African American, 14% Latinx, with representation from a few other race groups as well. Looking at our gender demographics, or our age demographics, we have an average age of 36 years old, median age 35. Our range is about 49 years. Moving into gender demographics, we are 67% male, 30% female. Jumping into the cross-tabulated questions, we asked a total of 56 multi-part questions. We look forward to doing additional analysis, but this is where we started. Our first question was, were you ever removed from your home by a social services agency? 28% of our sample experienced a home removal. 64% has not experienced a home removal. Looking at this data by race, we see that 25% of white respondents have experienced a home removal, 19% of Black respondents have experienced a home removal, and 28% of Latinx respondents have experienced a home removal. Moving into individualized education plan data, we see that 39% of our sample has been on an IEP, 53% has never been on an IEP. Looking at this data by race, we see that 44% of white respondents were on an IEP in school, 36% of Black respondents were on an IEP in school, and 25% of Latinx respondents were on an IEP while in school. Moving to our arrested under age 18 data, we see that 51% of our sample was arrested under the age of 18. 43% was not arrested under the age of 18. Looking at this data by race, we see that 43% of white respondents were arrested under age 18, 59% of Black respondents were arrested under age 18, and 39% of Latinx respondents were arrested under age 18. Our preliminary takeaways from these results are first, a need for greater data transparency. We need data at all major decision points of the child welfare and juvenile justice systems, and we need that data to be cross-tabulated by race and by disability. What we see is overrepresentation at these key entry points along the pipeline for Black and Latinx folks and for people with disabilities. In terms of promising interventions, we see preventing home removals as very important, so focus on family reunification rather than on home removals. We support kinship placements, which is where kids that are in the foster care system are sent to live with family rather than with strangers. And we support school discipline reform, pushing back against punitive school discipline policies to keep kids in school. Thank you so much for your time today, and we look forward to the panel.
Thank you.
Hello, today I'm going to be talking about anyone can respond, but follow-up is how you help people, enhancing police response to people with mental illnesses through a dedicated car. My name is Melissa Morabito from the University of Massachusetts Lowell, and this research was conducted in collaboration with Dr. Jenna Savage from the Boston Police Department. So when I talk about Boston Police Department's initiatives responding to people with mental illnesses in the community, I like to start off with this slide, because it really expresses how important the collaborative aspect of this is. The Boston Police Department works with Boston EMS, the Boston Medical Center, the Boston Emergency Services team to enhance its response on a regular basis. And so finding the right people is really important for making these initiatives work. Okay, so let's talk about some of the goals of the co-responder program. Now, for those of you who are not familiar, the co-response program involves a master's level clinician riding along with a police officer responding to calls for service for people in behavioral health crisis. The goal of this initiative is to divert people from arrest and to minimize their involvement with the criminal justice system. And while we have had a lot of focus traditionally and nationally on what happens in that acute incident, I would also like to talk today about what happens after the fact. And having that co-responding clinician, they can also facilitate more effective access to treatment services at that police point of contact. So we know at initial contact, community members may be resistant to accepting services. And it may be that somebody is just having their very worst day and is not open to any kind of help. Clinicians can provide follow-up that can allow for relationship building. So that can allow for increased opportunity to offer more and different services, but also to learn about what the needs are of that person, right? And make things fit better. So what can co-responding clinicians do? What do they do? There's specialized best clinicians, they respond to calls again alongside officers. So they're able to provide on-scene triage that can expand options for the disposition of the call. They arrive on scene with the officer, right, with lights and sirens, so they can get there quickly when necessary. What co-responders do is bridge communication between BPD and providers like hospitals and detox. So this expertise can help sometimes the community member navigate the fragmented treatment system. The co-responding clinician has tools that the officer does not have. What the clinician can also do is provide follow-up, which can reduce incidents in the future with the police or with EMS. Because remember, the policing model doesn't really necessarily call for district officers to go and see how things are going after they've responded to a call. But clinicians are in a different situation where they can do that follow-up. They can see how things are going on a regular basis and not involve the criminal justice system. So this presentation today, and I see them already halfway done, is around a dedicated car pilot. And so because of resource issues, clinicians ride along with district officers, and their goal is to primarily go to calls for service involving mental health, but that's not always the case. By dedicating a car, that car would not be asked to respond to other calls for service, only to mental health calls. And so for 1 month, one BPD officer responded with one clinician to all mental health calls identified by dispatch or by other officers or by the co-response team who listened along to the radio and may have thought, I know that address, we've been there before. When there were no calls, the team engaged in proactive work. This was conducted in Area C, and in the interest of providing necessary services, the team left Area C when requested specifically, but kept notes so we could track how much time they spent out of district. The pilot ran through 1 month, funded by the Department of Justice and supplemented by the Boston Police Department. We collected baseline data for the month before the pilot and then follow-up data for the month following the pilot. Okay, so here's some descriptive information for you. You can see that their number of calls for service went up dramatically during the pilot period. And what's interesting is that those calls for service remained up after the pilot period was over. And same thing for proactive contacts. The co-response team was able to make quite a few proactive contacts, 85 during the pilot period, but the number of proactive contacts, a rate of follow-ups, also increased during the follow-up period. And we suspect that as the program became more visible, more officers knew that it existed and were making more referrals to the co-responding team. So when we talk about proactive contacts, we're talking about follow-up calls or follow-up visits, assistance with restraining orders, or seeing somebody who looked like they were in need while the team was driving around. So there's all sorts of opportunities for that. So what happens then once the best connections are made? And again, we're talking more about what happens later and not just in that acute incident. And BEST is able to make low threshold, low barrier linkages to facilitate for easy transfer of care. And so some of that is through recovery coaches. BEST has walk-in addiction treatment, substance use disorder treatment referrals, and BEST also has walk-in urgent care, right, which you can get on-demand psychiatric evaluation. So BEST is able to do all that with these linkages. So some final thoughts: that most of the calls for service during the pilot period were not crime related. And there were arrests only, not actually any arrests at all. Future research should evaluate the effectiveness then to long-term services resulting from these proactive contacts. Thank you for your time and interest.
Good morning. My name is Laurie Becker, and I'm here to discuss with you my project titled Police Perceptions of Post-Overdose Outreach Program Effectiveness, a project that was done for my master's thesis in criminal justice at Roger Williams University. First, I would like to begin by giving you a brief introduction into this topic. Since 2000, the number of opioid-related overdose deaths in this country has quadrupled to nearly 500,000. This really came to a head in the year 2017, with this year alone seeing over 70,000 fatal overdoses, with nearly 50,000 of these involving opioids. Due in part to these statistics, in the fall of 2017, the United States Department of Health and Human Services came out and formally declared this current crisis a public health emergency. Looking at police response, police have historically been seen as fighting on the front lines against illicit drugs, and their position in this current crisis has proven to be no different. However, it has had to change form. Stemming from the war on drugs and continuing to the beginning of this crisis, law enforcement agencies devoted themselves to the traditional crime control model of policing, which was very enforcement driven, involving arrests for those found to be in possession of drugs as well as those found to be distributing drugs. As the epidemic got exponentially worse, many law enforcement agencies increased the use of these crime control methods as a means of reducing overdose deaths. However, what they saw was that overdose deaths continued to rise despite their increase in crime control methods. This led them to believe that these methods were not working and caused them to shift toward a more service-centered model of policing. Specifically in New England, armed with the mindset that we can't simply arrest ourselves out of this issue, police departments began to develop post-overdose outreach programs that involved officers making visits to the homes of those who had recently experienced a non-fatal overdose. And the purpose of these visits was very different from what we'd been seeing in the past. There was no enforcement component to these visits. Instead, the purpose was to offer the individual services and encourage him or her to enter treatment. While these outreach programs are gaining popularity throughout New England and throughout other areas of the country, it's important for us to understand how police officers perceive these programs. Which brings us to the purpose of our current study, which is to ascertain officers' perceptions of post-overdose outreach program effectiveness. In terms of the methodology, electronic surveys were sent to police officers employed by municipal police departments in Massachusetts, Rhode Island, and Connecticut. In particular, these three states were chosen as they are known to be significantly impacted by the current opioid crisis, as well as known to have high levels of participation in post-overdose outreach programs. As an overview of the analytical plan here, this study begins with univariate analysis that was conducted to determine whether police officers viewed these programs as effective, and ends with multivariate analysis in the form of ordinary least squares regression, which was conducted to determine what factors, if any, predict positive perceptions of program effectiveness. First, looking at our findings, in terms of the univariate analysis, program effectiveness was measured using 5 survey questions, the first being officers connecting the individual with substance use disorder with resources and treatment opportunities is helpful to the individual. And here we can see that the overwhelming majority of officers, 89%, agreed or strongly agreed with this statement. Moving to our second statement, slightly over half of officers, 52%, disagreed or strongly disagreed that the conversation the officer has with the individual with substance use disorder has an impact on whether or not he or she chooses to enter treatment. 3 out of 4 officers, or 75%, agreed or strongly agreed that officers are making a positive difference by engaging in these outreach visits. 56% of officers agreed or strongly agreed that police officers are effective agents in overdose prevention. Nearly 80% of officers, 78%, agreed or strongly agreed that whether or not the individual with substance use disorder enters treatment following the visit, the officer can continue to be a future resource to him or her. Moving into our multivariate analysis, looking at predictors of positive perceptions of program effectiveness, it was found that the following groups of officers are significantly more likely to perceive these programs as being effective. And these include officers who hold a college degree, officers who have more innovative or service-centered views on policing, officers who view addiction as an external force or do not view the individual to be responsible for his or her addiction, officers who are inclined to offer individuals with substance use disorder services and treatment, officers who view the opioid epidemic as highly important or a pressing issue that police should be focusing on, officers who feel that their department has laid out clear expectations of its officers in relation to the task of outreach, and lastly, officers who believe that police officers have the power to prevent future overdoses. Concluding with some practical implications, in order to increase the likelihood of officers viewing these programs as effective, a critical first step is to increase the support or buy-in of these related concepts. First, it is recommended to increase officers' exposure of innovative policing ideals, as it is seen that officers who hold more service-centered views also see these programs as effective. Second, it is recommended to increase training on addiction and recovery, as officers who view addiction as not being the responsibility of the individual are more likely to support these programs. Third, it is recommended to hold trainings related to overdose outreach programs specifically. They can help to increase officers' feelings of importance of the opioid epidemic, increase their understanding of what outreach entails and what is expected of them on these outreach visits, and incorporate success stories of individuals who were positively impacted by an outreach visit and have since engaged in treatment and/or stopped using drugs. And lastly, it is recommended that departments look into incentivizing the attainment of college degrees, as officers with higher degrees are more likely to see these programs as effective. Thank you.
Hello, everyone, and welcome to our session on domestic violence prevention and outcomes assessment during COVID-19 and beyond. My name is Dan Jackson. I'm the Executive Director of the New Law Lab at Northeastern University School of Law.
Good afternoon, everyone. My name is Margot Lindauer. I'm the Director of the Domestic Violence Institute and the Director of the Clinical Programs at Northeastern University School of Law.
Good afternoon. My name is Morgan Wilson. I am a legal fellow with the Domestic Violence Institute at Northeastern University School of Law.
Hello, my name is Gemma McFarland. I'm a doctoral student in sociology at Northeastern, and I'm also a research assistant at the Domestic Violence Institute.
I want to take everyone back to March 2020. I was operating and directing the domestic violence clinic at that time. We were in the beginning weeks of our spring quarter. The domestic violence clinic is an academic class at the law school for upper level law students where students practice under my bar certification. The class has two components. One is a seminar component that I teach, and the other is an in-person advocacy component where students represent individuals impacted by intimate partner violence, primarily out of the Boston Municipal Court and primarily out of the Dorchester Division of the Boston Municipal Court. The clinic historically prior to March 2020 received our clients in two main ways. One was by sitting in the clerk's office and meeting clients as they applied for and sought legal intervention to their intimate partner violence issues. The other was through direct referrals from our robust network of community health providers, mainly the Boston Medical Center, Children's Hospital, and other community health centers in the community that have a robust domestic violence programs. What we saw in the beginning of March 2020 was not unlike other domestic violence programs nationwide, was a precipitous decrease in the number of intakes and referrals we received. One was because of the physical closure. We were unable to go to the court and see and meet clients where they first turned to for help. But also our community partners were unable to see and work with their participants. And so we were at a standstill where we knew that this decrease in number of intakes and people reaching out for our services was not at all indicative of what was happening in the community. In fact, we knew that domestic violence was increasing in times of stress, economic instability, and in this case, all other forms of instability, housing, health, community instability, academic instability for children. We knew that domestic violence was increasing and the numbers were not at all indicative of the public health crisis that was just beginning to happen. And so we sought to partner with the Law Lab to expand our services, the domestic violence clinic services. And in doing that, we also wanted to commit to increasing shelter space if possible, while we increased technological interventions.
Thank you, Margot. So I'm going to walk you through very quickly the two interventions, or at least the first of the two interventions that we created. The first was to create a very straightforward, simple website built on Squarespace that would allow individuals to access DVI Legal's resources remotely without having to go to court, which was obviously closed. The website, as you can see, is very simple in its structure. It is available in 4 languages: English, Spanish, Haitian Creole, and Portuguese. It provides information about DVI Legal, the clinic, the process, the team, as well as some resources for individuals who may not be quite ready for the help of DVI Legal, but most crucially, for purposes of the immediate intervention during the pandemic, basic, simple intake form that is powered by FormStack that provides individuals the access to DVI Legal's resources online without having to actually interact with an individual. The other, of course, important component part of this was to make use of underutilized hotel rooms due to the decrease in business travel as part of the emergency shelter component.
Thank you, Dan. So as Margot mentioned, there was a significant decrease in the number of people reaching out for help at the beginning of the pandemic. But what we know is that actually due to the nature of stay-at-home orders, that the need for domestic violence services increased. We saw a 300% increase in people reaching out for services when technological interventions caught up with the need. And so beginning January of last year until present day, we have served 175 clients. 149 of those clients have been clients that we've served since March. When the pandemic began. So as you can see here, this is a screenshot of our quarterly newsletter. We have served as part of our expanded services, this new shelter component, 27 individuals, 18 of whom are children. This amounts to about 9 families in shelter. Most of our families have multiple children, typically anywhere from 2 to 3. And the average length of stay is about 3 to 4 months in our shelter before families transition into long-term stable housing. And so right now we still have about 3 families. We have 3 families, remaining in shelter. It's for a total of 8 people. They are working with our housing partners to be able to move into long-term stable housing. So we've had nearly a 100% success rate with getting people long-term stable housing. The other thing, as Dan mentioned, our website launched July 1st of last year. Since that time, in addition to referrals from our community partners in the health space, as well as faith-based communities and other grassroots organization, we have received 21 referrals through our online intake portal. All of those clients receive a callback and assistance from DVI within 24 to 48 hours.
So prior to March of 2020, information was gathered about DVI clients through an in-person intake, but these processes varied depending on who was conducting the intake and how many questions they were able to ask during a given intake period. We weren't really able to capture rich data that would allow us to better understand what was happening in the community. So the DVI shifted its focus to prioritize digital intake through our existing case management system called Clio. So Clio is a very clunky legal case management system, but fortunately we were able to add customizable fields that would serve as both a legal prompt for clinic staff who were doing the intake with clients and simultaneously allow us to gather more nuanced information from clients that might help us to better understand the impact of our services. This information includes types of abuse, lethality, length of abuse, children involved, court outcomes, and also demographic information like age, race, gender, and zip code, information that was already being gathered, but wasn't organized in a way that we could ever really go back and see like what the true impact of our services really are. As we moved into the digital context for intake, we also realized that we weren't really capturing technology facilitated abuse, which is something that we've seen an uptick in, especially since the beginning of the COVID-19 pandemic, like cyber stalking and harassment through technology generally. So since then, we've added questions into our intake processes to actually reflect these types of abuse as well.
We look forward to answering your questions and having a conversation during the latter portion of this panel. Thank you very much for your time and attention.
As we come back into our room, I want to thank each of the panelists for their wonderful presentations, very insightful presentations. Dr. Lindauer, I think as you were making your presentation, the last part, we weren't able to show the website for your work. And
yeah, I can add it to the chat.
Yeah, if you can add it to the chat so that folks, because there were folks who were asking about that.
Absolutely, thank you.
Wonderful.
Oh, it's already there. Okay.
Okay, great. So I just wanted to sort of help set the context by when we talk about innovations in criminal justice and ask a general question so that you all could answer. And then I have some specific questions for you. And not too tough. We're just trying to get this conversation going. But we're in a fascinating time in our country when it comes to issues around criminal justice. And there are some folks who would say the more things change, the more things stay the same. And although we have some innovations that are happening and some that's on this panel, there are always pockets of resistance, that seek to minimize any innovation that comes to the fore. And I think for your areas of expertise, what would you call that resistance, and what does that look like? And then how would you be able to get around it? Would be my general question. Now, I'm Baptist, so I can even answer my questions and talk for a long time, but I'm looking for somebody to respond.
Do you want us to go in the order that we presented in, or does it matter?
Sure. That'd be fine.
I can just get the conversation started. I think for our project, the Cradle to Prison Pipeline Project, we've looked to address resistance through data transparency. And I think that's a way we've seen reforms in policing and lots of other areas in the criminal legal system around the country, is by, just availability of data, understanding what's going on, understanding that the data shows that Black men are twice as likely to get killed by police officers, for example. And so we're seeking to do something different on the pipeline side, which is to still with the focus of addressing mass incarceration, but widening the lens and looking at who's incarcerated and what was their life before, what childhood experiences did they have, what systems involvement did they have, and by providing the data, some of the data that Aaron very briefly provided in our pre-recorded presentation, we're looking at over half of people who we surveyed who are incarcerated were arrested before age 18. That's really telling. Almost a third were removed from their home. That's the most extreme DCF action available. And again, a startling number. So our hope is that making this kind of data available will be a way of addressing some of the resistance that we might otherwise encounter.
Dr. Melissa?
Okay, well, that's a hard one here. There are definitely people who believe that the police should not be responding to calls for service and involve mental health. And I happen to be one of those people. Unfortunately, I think that there will always be a time where there are some calls that will go to 911 and will get a police response. And I see my work and the work I'm doing with the Boston Police Department as how do we make that response the best possible? And co-response seems to be a way to make sure that residents of Boston and residents everywhere, right, are getting access to the long-term services they need. We should absolutely be, getting better mental health services to people in the community, but I cannot foresee a time where there will be no calls to 911 about people who end up having some sort of behavioral health issue that needs to be addressed.
Thank you. Dr. Laurie?
Sure. So similar to what Melissa had said, there are people who do not believe that police should be responding to overdoses, do not believe that police should be kind of involved in this area of addiction. And I think kind of the way to combat that is to make sure that if officers are involved in this process, that they are involved in the best way that they can be. And one way to do that is to kind of change these viewpoints around addiction to make sure that police are understanding that this is a public health issue and kind of break down those barriers of stigma and always involving a criminal justice response to things. And I think that the more they're trained in these things, the more they're exposed to these kind of visits and meeting individuals who are impacted by addiction, the more they will want to be involved in these programs and offer treatment to the best of their abilities.
Thank you. And Dr. Margo?
Sorry. Our work is a little kind of outside of criminal justice specifically, but we have quite a bit of intersection with the criminal justice system, and many of our clients are system involved. So I would say, similar to Professor Hartung, one of the strengths that this project brings to this area is data, and data that shows gaps. Our clients are always falling through the cracks and have many of the same adverse child experiences that Professor Hartung's population has as well. And so our hope is that by tracking our clients, tracking where they're coming from, where they're ending up in permanent housing and how they're doing and what services have and are effective, we can expand our services, but also be a model nationwide.
Right. It's so interesting because some of your responses sort of gets to the heart of what do we do with policing in the future, you know, and I'm not just talking about, you know, the calls to, you know, defund police, whatever, but I'm talking about the role of policing and do we have police officers work with social workers, and is that a partnership, for example, or is it just another tool in the policing toolbox that they pull out, you know, when they judge it's needed? And when we talk about domestic violence, we are also talking about policing because there is high levels of domestic violence, you know, among policing families. And, you know, so the question is, how much of this do we relegate to policing? And then how much of this goes into the creation of something different? And I want to ask that in the question, but I also wanted to talk to Professor Stephanie, because I was thinking about that cradle to prison pipeline and the role of trauma, you know, in the driving of that. And I'm wondering, in your survey, have you tracked for that? And even as we think about the survey itself, because, you know, some of those questions are very personal and may be perceived as invasive, do you check for trauma, you know, even the administering of the survey?
Thanks for that question, Reverend Brown. And I'm gonna, after a brief comment, turn it over to Aaron to answer this question. But we absolutely did consider early childhood trauma, and it was a big part of the framing of the survey. And as you suggested, finding that balance between not wanting to re-traumatize people participating in the survey. So we focused on what are called ACEs factors, adverse childhood experiences, and that was a part of the way we framed our survey. But I'm going to let Dan, if you could enable Aaron to answer that question, that would be great. Thank you.
Yeah, hello. Thanks so much, Stephanie, for sending the question over to me. I'm happy to talk about it. Definitely, we focused a lot on adverse childhood experiences while developing the survey. And we also discussed a lot, you know, the trauma and the experience of folks taking it. So the first thing that we did is we had a pilot survey with 27 returning citizens who took our survey and talked to us about what it was like to take it. And so they also, you know, gave us some ideas for how to shape questions differently. They gave us ideas for, you know, new questions that we could throw in. And so we really used them, you know, as partners to tell us, you know, what the survey is like and also how they benefited from the survey. And so a lot of what we heard is actually the folks taking it felt really grateful to be asked the questions and to be given the opportunity to speak about their lived experiences, when I feel like that, you know, is not allowed or not very forthcoming in prison.
So were there any negative reactions to that surveying, and then how did you handle that?
Yeah, that's a really good question. So in our pilot survey, we actually didn't have any negative responses. Most of them were very, very positive, which I was honestly surprised by because the questions are very personal. In terms of our final survey, I'm not sure like what, you know, what folks were saying behind the wall about the survey. I would, you know, really love to get more insight on that, but, you know, we aren't as aware of that. But yeah, we haven't gotten any, you know, notices about responses. Obviously, you know, we spoke to people, or we provided in our written materials, you know, resources that folks could reach out to. Obviously, those resources change a lot depending on what the institution is as well.
Just got another question for Dr. Laurie. I was thinking about the buy-in that's required in order for, you know, not just individual officers, but departments to embrace this approach. as as we continue in this huge crisis around opioids. And you were saying that training is important, and educational incentivizing would also be important. But I'm also thinking about the relationship between supervisor and patrol officer. So your sergeants and those other types of supervising. Do you think that it's important for them to also be educated around this? Because we know that their influence is a very important part of what's going on the ground with policing.
Absolutely, and that was something that our study looked at, and we found that there were positive perceptions all throughout the ranks. And I think one of the things that has been happening in many departments is that they were choosing which officers would go out on these visits and which officers would be involved. So there wasn't a lot of knowledge throughout the department about this. And I think that really impacted how officers across the board were responding to these types of calls. So I think the more we educate the middle command staff, the sergeants and lieutenants who are actually have the most impact on the officers who are actually out on the streets, the more we will see changing perceptions from these officers as well.
Right. So, I just want to ask another general question, because I noticed that we're at 11:54 and they're going to give us the hook in a minute. I've looked at the Google Docs, Dan, also, and I haven't seen any questions that's been coming from the audience. So just let me ask this general question, because we are in a moment now in our country where, as we think about reforming criminal justice and reforming policing, that race plays a huge factor. And each of your research areas, in a way, sort of touches and intersects, with that. And so I'm thinking about, how do we move forward? What would be your ideas around moving forward? And if we can start with the last one and then sort of go to the first one. So Dr. Margot, if we start with you, and then Dr. Lloyd.
Yeah, Reverend, I'd like you to, or Dan, can you open this up to Gemma and Morgan, who are my collaborators, answering the question about how race plays into the work that we do and how we're factoring that into the work going forward. I think Morgan would be.
Hi, can you hear me?
Yes.
Yes. Thanks, Morgan.
Thank you. So thank you so much for having us and for this question. So the majority of the clients that we serve in the Domestic Violence Institute identify as part of a BIPOC community, so Black, Indigenous, people of color. And so I think looking at both the intersection of race, class, gender, as well as their sort of economic status has a huge role in the way that we understand the work that we do and the provision of services, right? And so if we know, for example, that the majority of our clients identify along a racial group that has a history of sort of a negative rapport with police or with the criminal punishment system, and that might inform the way in which they choose to engage or not engage with the criminal punishment system, the criminal legal system, and the civil, legal system, then we can inform the sort of wraparound holistic legal and social services support that we provide along those lines. And so we make sure that we collect data about race, class, gender, sort of sexual orientation, economic status about our clients, so that we are providing wraparound services that meet the needs of our client, so that they make decisions not in trauma, but from a place of being supported.
Thank you for that. Got time for one more, if we could shoehorn it in. Gemma, did you want to respond? And if not, we go to Dr. Laurie.
Yeah, I mean, Morgan pretty much covered it. I think adding in the sort of data piece to our intake services was a huge component to this. We sort of had anecdotal evidence surrounding race, class, and gender, but we didn't really have a place where we were able to like pull it and actually say, no, these are the services that we provide, and this is who we're providing them to. So I think that's going to play a major role in obviously the way that we provide services, but also in the way that we are able to sort of understand the communities that we serve.
Got it. Thank you. Dr. Laurie, see if you can get one in there.
Sure. So I think in terms of race and police officers responding to overdose victims, a big thing we need to focus on is representation. And from my survey sample, it was 89% white. So I think including more officers of differing races, as well as including recovery coaches of a variety of races, can help to work with overdose victims and show that they understand the different racial components and how these people view their addiction and view treatment.
Okay. Well, I see that our time is up. I was actually having a great time, and I'm hoping that there's some ways in which we can do some follow-up. So Dan, back to you.
All right, sounds good. Well, thank you, Reverend, and thank you to all the speakers and all the colleagues. This is a great conversation. And thank you to everyone who joined us today. So it's my job to basically say, have a great weekend. And we will see everyone back here next Friday morning. Very much looking forward to it. Thank you again to all the speakers, and we'll see you soon.
Thank you.
Thank you.